another very important session. Now, this is a topic which has been in demand, in fact, and that's why we have included this topic. And we have a very expert person talking about it, Dr. DC Sharma. And I have Dr. Bhushan Hathi as the chairperson for this session, and Dr. CK Lora, who is the moderator. Over to Dr. Bhushan Hathi to please take the session forward and introduce Dr. DC Sharma, please.
Hello, everyone and friends. It's great to be a part of this academic feast. Introducing Dr. DC Sharma to the society is only a matter of my privilege. He needs no introduction. He is very much a part of this society and diabetes forum as such. At every fora, he is a very important part of the total deliberations. Still, continuing the protocol, Dr. DC Sharma is MD CEO of Strajan Hospital, Udaipur. He was formerly Professor and Chief of the Clinical Unit of Endocrinology, R&T Medical College, Udaipur. He has many publications to his credit across the globe. He's a well-known speaker, as we have been listening to him frequently. And I would request Dr. DC Sharma, sir, to please share his knowledge with us.
Thank you, everyone. Thank you, Dr. Menawat, the whole team for inviting me. Thank you, chairpersons, for the kind introduction, and all dear friends. It is an opportunity to connect to you, at least virtually, through this forum. So, dear friends, as has been introduced by Dr. Menawat sir about the glucocorticoid withdrawal. In fact, glucocorticoid drugs are one of the most potent anti-inflammatory and immunosuppressive drugs available to us. And because of this property, they are being used in variety of medical and systemic disorders, say respiratory disorders, the collagen vascular disorder, the dermatological disorders, neurological disorders. They are very effective immunomodulatory and immunosuppressive drugs. But at the same time, the side effects prevents their widespread and long use. The adverse effect comes in, and they prevent the use of these drugs in long term. So despite its efficacy, steroid-induced side effects generally require tapering of the drug as soon as the disease being treated is under control. And this is because longer you use it, longer are the chances of the side effects being there, and suppressibility of the hypothalamic pituitary adrenal axis. So treatment must be done carefully to avoid both recurrent activity of the drug underlying the disease and possible cortisol deficiency resulting from hypothalamic pituitary adrenal axis suppression. This is relevant since you cannot use it for a long period, and if you plan to stop or taper it, then you have to balance by reducing the drug or stopping the drug. The symptoms and signs of the underlying disease for which the steroids were given, they might appear. And at the same time, if you're not able to taper, then the side effects of the drug might be there. And because of the long-term use of the steroid, there may be suppression of the hypothalamic pituitary adrenal axis. And so suddenly stopping the drug might precipitate the features of acute adrenal insufficiency. So when do you want to withdraw the drug? The indications for withdrawing corticosteroids could be in the form of when the maximum therapeutic benefit has been achieved by the drug steroid, when you are giving adequate dose but still you don't find adequate therapeutic response, then you may try the drug might have been given as a trial, so you may like to taper the dose or stop the drug. Thirdly, when side effects of the long-term use of the drug, say hyperglycemia, osteoporosis, or hypertension, become serious, uncontrollable with medications, then under these situations, you may have to, taper the drug or stop the drug. There are two complications that require immediate cessation of glucocorticoids or a rapid reduction of the dose rather than tapering. And I would like to mention these situations. That one is acute psychosis, which is unresponsive to antipsychotic medications, and here you may have to rapidly taper or stop the treatment. Second is herpes virus induced corneal ulceration, which can rapidly lead to perforation of the cornea and possibly permanent blindness or visual loss. Barring these two conditions, you require the drug to be tapered. Now, before I come to the tapering protocol and withdrawal protocol, let me remind you, let me recapitulate the normal physiology that long-term steroid, how the long-term use of the steroid would lead to suppression of the HPA axis. Normally, the hypothalamus activation leads to secretion of CRH, the corticotropin releasing hormone, which in turn stimulates pituitary. Pituitary secretes ACTH, and ACTH in turn stimulates adrenal cortex to release cortisol hormone. Both the cortisol as well as ACTH, maybe exogenous or endogenous, would lead to suppression of the pituitary and hypothalamus. So this is important to understand. Now, we discussed the withdrawal protocol. While you are giving steroids to a patient, it is important to recognize which patients are likely to have hypothalamic pituitary adrenal axis suppression, and in this situation you may be recommended to taper the dose rather than suddenly stopping. So clinically it is important to identify patients who are likely to have suppression and those who are not likely to have suppression. In fact, the potency, dose, and duration of glucocorticoid use are important to understand and to know that this much amount of steroid, this much dose of the steroid, this particular type of steroid, and duration of steroid is likely to lead to suppression. But then these are imperfect predictors of the presence of HPA suppression. Some patients may have partial suppression. Some patient may have complete suppression, despite of short-term use of the steroid. That's why a clinical decision about a particular patient's risk of having HPA suppression guides subsequent decision making about glucocorticoid tapering and what the situation you have to see. Before I come to recognizing clinically, let us again discuss the various types of glucocorticoid preparations available to us. And to simplify, I would say that naturally occurring steroid is cortisol. So hydrocortisone mimics the naturally secreted cortisol from the adrenals, and normally around 20 to 32 milligram of the cortisol is secreted per day. The dose equivalents of various steroids are hydrocortisone 20 milligram is equivalent to 5 milligram of prednisolone, 4 milligram of methylprednisolone, 4 milligram of triamcinolone, and dexa and betamethasone are more longer acting and more potent drugs. So their equivalent is 0.75 and 0.6 milligram respectively. Why is it important to know? Because while you are tapering, you should know what dose to taper. And I'll come to this point again, but this is important to keep in mind. Furthermore, as you descend in this table from top to bottom, the duration of action of the drug it gets prolonged. So the hydrocortisone is shortest acting, then prednisolone, methylprednisolone are intermediate acting, while dexa and betamethasone drugs are longer acting. Longer the steroid action, more is the chances of suppression of the HPA axis. Shorter the duration of action, lesser are the chances of suppression of HPA axis. So, which risk factors for suppression of the HPA axis when patient is receiving glucocorticoid therapy? These are some of the parameters which help you guide that there is a greater risk or lesser risk of suppression of the HPA axis. For example, treatment dose, higher the dose, higher are the chances. Maintenance dose, less are the chances. Split dose, if you give steroid in the split doses, there are less chances rather than single dose being given in the evening. Okay, greater chances if the single dose is given in the evening. Daily doses, more chances. Alternate doses, less chances. Long-acting steroid, I mentioned, there are higher chances of suppression. Short-acting steroid, less chances. Systemic use, more chances. Topical use, inhalational use, less chances. Prolonged use, more chances of greater risk of suppression. And short-term use, less chances of suppression of HPXs. So after having seen and realized these parameters of various glucocorticoids, let us see clinically how do you recognize in a given patient that he is likely to have HPA suppression, and then you are recommended to taper the drugs, the glucocorticoid. In fact, anyone who has received a glucocorticoid dose comparable with more than 20 milligram of prednisolone a day for more than 3 weeks is likely to have HPA suppression, and he is a candidate for tapering. So now you would appreciate why I mentioned the table previously. So 20 milligram of 20 milligram of prednisolone is maybe 100 milligram of hydrocortisone, and maybe 1 milligram of dexamethasone for more than 3 weeks. Anyone who has received an evening or bedtime dose of more than equal or more than 5 milligram of prednisolone for more than a few weeks, he is again likely to have HPA suppression and would require tapering rather than suddenly stopping. Third and most important clinical parameter is any patient who has received glucocorticoid for any duration in any dose. If he has developed Cushingoid appearance, this should be taken for granted that this patient has HPA excess suppression and steroid should not be stopped suddenly. Otherwise, he is likely to develop acute adrenal insufficiency. On the other hand, there are clinical situations when HPA excess suppression is unlikely. For example, a patient who has received any dose of glucocorticoid for less than 3 weeks. So any dose less than 3 weeks, unlikely. Patient treated with an alternative day prednisolone regimen of less than 10 milligram or its equivalent is unlikely. So less than 3 weeks, any dose, and less than 10 milligram of the prednisolone. In between are the patients who have intermediate or uncertain risk of HPA excess suppression, and you have to be cautious. For example, patients taking 10 to 20 milligram of prednisolone per day for more than 3 weeks, I mean less than 20 milligram for more than 3 weeks, and patient who has taken less than 10 milligram on alternate dose or maybe a single bedtime dose, you do not know. So you have to be cautious. So after having clinically recognized which patients are likely to have HPA excess suppression and you require tapering, before I come to the withdrawal protocols, let us understand, and this is very important to keep in mind to understand the tapering protocol. This photograph is to basically show the recovery of the hypothalamic pituitary adrenal axis after suppression of chronic glucocorticoid therapy. I mean, when you give steroid for, say, for example, more than 3 weeks, high doses, and you are suspecting suppression, and you stop the drug, uh, the time to recover, I mean, it's in months. It's important to keep in mind, it's in months that serum cortisol would recover. The serum cortisol would recover after 2 to 5 months of stopping the drug, while the ACTH is likely to recover little early. So first thing to be recovered in the HPA axis is ACTH. So first ACTH starts recovering. It might be normalized or might be little higher in order to push the adrenals to secrete required amount of steroids. Okay, then comes the recovery of basal cortisol, and lastly comes the recovery of the complete axis, where when you stimulate the HP axis by various stimulation protocol, you are likely to have normal response at hypothalamus, pituitary, as well as adrenal, and this takes about 9 months. So dear friends, it is important to recognize that some patients may not have complete recovery as long as maybe a year or even 1.5 years. Why I'm mentioning this? Because even though patient is clinically, apparently normal and completely recovered, but this patient who has been withdrawn from steroid and now, say, undergoes a surgery or any acute, he falls sick of any medical or surgical disease, he might require supplemental dose under this stress response. So you have to document the complete recovery of HPXs before you can ask the patient to with discharge from your supervision, or say him that he is completely recovered. Now, what is the goal of tapering? The goal of tapering and glucocorticoid therapy is we have to use a rate of change that will prevent both recurrent activity of the underlying disease and symptoms of cortisol deficiency due to persistent HPS suppression. Making it simple, while I'm withdrawing the drug, I should keep in mind and I should be watchful that the drug for which I had the condition for which, for example, rheumatoid, or for example, SLE, the features of SLE or rheumatoid should not appear or flare up, and at the same time I should not have features of adrenal insufficiency. So the goal of tapering is to prevent recurrent activity of the underlying disease for which the drug was given and to prevent HPA excess suppression features. The recommended tapering regimen are Short-term glucocorticoid therapy. Now, this is important. Up to 3 weeks, even if at a fairly high dose, can simply be stopped and need not be tapered. So, any dose of the steroid given for less than 3 weeks, you can stop. For example, most of the patients in whom we gave steroid for COVID-19 infection, but patients who required long-term therapy for long COVID, my other physician friends, you all would be knowing much better than me, they might be requiring tapering. In patients who have taken steroid for a longer time, tapering is required. Okay, so the aim of relatively stable decrement of 10 to 20% while accommodating convenience and individual patient response. So the aim is reduce it at a time by only 10 to 20% of the dose being given. And and the dose tapering is done as 5 to 10 milligram per day of prednisolone to be reduced 1 to 2 weeks from an initial dose of 40 milligram. So if the patient was receiving 60 milligram or 70 milligram, then reduce it by 5 to 10 milligram per day every 1 to 2 weeks. Okay, prednisolone or its equivalent. Then when the dose comes to 20 to 40 milligram of prednisolone, reduce it to 5 milligram every 1 to 2 weeks. When you reach a dose, prednisolone dose of 10 to 20 milligram, make it 2.5 milligram day every 2 to 4 weeks. Once you achieve a dose of 5 to 10 milligram, that is physiological, near physiological dose replacement, then uh, 1 milligram per day dose reduction every 2 to 4 weeks. Okay, and then further, when you reach physiological dose, that is 5 milligram per day, then the dose reduction would be zero point 0.5 milligram per day every 2 to 4 weeks. Or alternatively, when you reach physiological dose replacement, that is once you reach a 5 milligram prednisolone dose, you can switch over to hydrocortisone, which will help you recover the HP excess better. So once 5 milligram prednisolone dose is reached, switch the patient to hydrocortisone 20 milligram per day and reduce the hydrocortisone dose by 2.5 milligram per day every week to 10 milligram per day. Okay, so once you come down to this dose of 5 to 10 milligram of hydrocortisone, then you submit the patient, and when patient is clinically stable, I mean, when the features of underlying disease does not appear and patient is stable, there are no features of adrenal insufficiency, maintaining this dose, you stop hydrocortisone for 12 to 24 hours and submit the patient to stimulation test. So after 2 to 3 weeks of reduced dose, check basal serum cortisol or carry out Saracen stimulation test for recovery of HP excess. So there are two options. Check the serum cortisol. If the serum cortisol is more than 15 milligram, you can be reassured that your patient has no suppression, and you can discharge the patient from your follow-up. If it is less than 5, you should not stop the drug. You should continue giving steroid and maybe wait for a while. In between, you continue the dose and recheck the recovery of the HV excess, say after a few weeks. So testing for HV excess is appropriate when patient is using less than 5 milligram. I'm repeating, and there's difficulty in reducing the dose further because of known disease-related symptoms. Okay. The alternate day regimen is also there. So this was daily regimen. Now, uh, the previous regimen I discussed was much more validated, scientifically proven, while there are positive data regarding alternate day tapering regimens. In alternate day tapering regimen, what you do is once the a daily regimen has reached 20 to 30 milligram of prednisolone per day, then decrease the alternate day dose by 5 milligram every 1 to 2 weeks until the dose is 20 to 30 milligram, alternating with 10 milligram. Then reduce the alternate dose by 2.5 milligram every 1 to 2 weeks until the prednisolone dose on the alternate day has fallen to zero. So maintain 20 to 30 milligram, reduce it by 10 milligram, and on the alternate day, reduce it by 2.5 milligram every 1 to 2 weeks when the alternate day dose is reduced to zero. Then once the dose has come down to the alternate day dose has come down to 5 to 10 milligram, maybe you switch over to hydrocortisone or taper it by 1 milligram prednisolone every alternate day till a patient is stable, and then you submit the patient to testing for the recovery. To summarize whatever I have discussed, the glucocorticoid therapy for more than 3 weeks or appearance of Cushingoid appearance suggests that your patient has HPS suppression and you are warranted to gradually withdraw glucocorticoid or taper glucocorticoid. On the other hand, if patient has received any amount of steroid for less than 3 weeks, you can stop it. Or prednisolone dose, alternate day dose of less than 10 milligram, you can stop. Cessation can be done. But while tapering or while stopping, if patient has features of adrenal insufficiency, and mind it, the features of adrenal insufficiency are very vague. Patient may just complain of fatigue, lethargy, postural symptoms, maybe a little low-grade fever, loss of appetite, and some bowel disturbance, and likewise. So you have to be watchful about these symptoms. Then start glucocorticoid replacement. Then, as I mentioned, gradually reduce it. Check once your physiological replacement dose is reached, then you check for the recovery by basal cortisol or by short connecting testing, and then follow the patient and likewise. So, dear friends, I would like to summarize and say that tapering must be done carefully to avoid both recurrent activity of the underlying disease and possible cortisol deficiency resulting from HPA excess suppression. Identifying patients with HPA suppression is important. Clinically, you can take a decision to taper or suddenly stop the drug. Taper the dose of glucocorticoid till physiological glucocorticoid dose is reached, that is 5 milligram of prednisolone or less. At this time, maintain it, and after 2 to 3 weeks, check for the recovery of the HPA excess by basal serum cortisol or by submitting the patient to short sanitary testing. Thank you very much for your interest and patience. I would be happy to interact and answer any questions if they.
Thank you very much, Dr. DC Sharma sir. My personal impression about this talk is that I would like to listen to this talk at least 3 more times to get all the pearls that you have distributed in this talk. This is very, very important clinically, and I'm really thankful to you for the talk.
Okay, so I think there is some problem with the connection. Uh, Thank you very much, Dr. DC Sharma, for this wonderful and very important topic which you have taken up. In fact, it is required by all clinicians to know a very important drug like steroids, how they have to be used and how they have to be withdrawn. I can give my comment on this. There are two things which you have really pointed out. There are quite a large number who think that once you start steroid, they have to be withdrawn gradually always. Whereas you have been very clearly emphasizing that if 3 weeks steroid don't require withdrawal very quickly. They can be done very quickly. They don't have to be withdrawn gradually. This is one very clear indication that 2 to 3 weeks steroid is okay. And this is a scenario in our patients with COVID. I must say that you must have seen that people are using 16 milligram for 3 days and then 8 milligram for 3 days and 8 milligram for 1 day, whereas this is not required. In fact, if you use it for 5 or 6 days, you can withdraw it immediately. That's one important thing. And second, there was a concern that there was a concept of using ACTH injection in between by many people uh, to take care of the HPA, the suppression. I remember in our good student times, we were taught that ACTH injection is given once in 6 months for those people who are taking steroids for a longer time, can maintain the HPA. Is that possible? If you are able to answer, it's okay. Or I can ask Dr. S.K. Sharma for this.
Twice in a week.
DC, there is a connection defect, I think.
Yes, yes. But Sharma Sahab, have you been able to understand my question?
Well, absolutely right that when we are giving for a shorter time, we can withdraw it.
Prednisolone as an intermediate action, as I mentioned, it is 12 to 18 hours. That particular steroid can be used alternative regimen While if you are using hydrocortisone, this cannot be as an alternative regimen. So if the on, then you have over to intermediate rating when you are in the logical range, change it over to prednisolone, and